All right, we've got a good number of folks who have joined us so far, so we are going to go ahead and get started. Good morning, everyone, and welcome to the Immune Deficiency Foundation's Lunch and Learn series. Today's program will explore Hyper IgM Syndrome with Dr. Andrew Gennery from Newcastle University. My name is Emma Mertens, and I am the Program Manager of Community Relations at IDF. On behalf of all of us at the Immune Deficiency Foundation, I'd like to thank you for joining us today for this Lunch and Learn. We are excited to host this webinar for the IDF community. IDF is dedicated to fostering a community empowered by education. We want you to remember that IDF is committed to our community, serving you as a trusted resource through the use of technology and innovation. We are here to give you the tools and information to become empowered and offer you our support, compassion, and understanding to emphasize that you are not alone on your journey. We would like to thank our partner, the Hyper IgM Foundation, for supporting today's Lunch and Learn. We will be hearing from them later on in today's program. Before we begin, I would like to point out a few housekeeping items to keep in mind for today's Lunch and Learn. This morning, we are using the Zoom webinar feature. Attendees should be able to see the slides and our panelists and be able to hear myself and the presenters. Attendees will not be able to activate their video camera or microphone. There will be the opportunity for questions at the end of the presentation. You are welcome to submit any questions you have for our panelists as you think of them throughout the session. Please type them in the Q&A box in the control panel on your screen. Please do not include any personal health information, as all questions will be anonymous and read aloud. A brief disclaimer. Please remember that information presented during this forum is not intended to be a substitute for medical advice, diagnosis, or treatment. We are here today as a trusted source and friend to provide you with information. Always seek the advice of your physician or other qualified health provider with questions concerning a medical condition. Never disregard professional medical advice or delay seeking it based on information presented during an educational forum or event. To learn about IDF and explore our resources, please visit our website at www.primaryimmune.org. The website offers a wide variety of online and printable resources for anyone seeking information or support for PI. This includes the Patient and Family Handbook for Primary Immunodeficiency Diseases, which actually features a chapter dedicated to Hyper IgM. We encourage you to visit the IDF Resource Center, where you can find all IDF publications, videos, news, and more. In case you didn't know, IDF also offers monthly programming and events. In addition to our Lunch and Learns, we host 2 IDF forums a month, and we also have Get Connected groups, peer support, and Ask IDF. We're also always thinking of ways to bring the latest in PI to you, such as the 2022 Primary Immunodeficiency Conference. We hope you'll save the date for this hybrid 3-day experience coming to you in the fall. That's October 6th through the 8th. And without further ado, I'm very pleased to introduce our speaker for today, Dr. Andrew Gennery. Welcome, Dr. Gennery.
Thank you very much, and thank you for inviting me to talk. It's nice to see one or two, say, old friends on the call, maybe long-standing friends, shall we say. Hi. I'd like to take actually just a few moments to remember other things that are going on in the world. I think we are one community of patients, physicians, and scientists, and particularly in Ukraine at the moment, there are absolutely catastrophic things happening, but actually even in Russia, where I have colleagues and friends involved in the field who are struggling on their day-to-day work at the moment because they don't have access to the things that they had access to just 3 weeks ago. And let's just hope that this horrible situation resolves quickly and we can get back to being a family together again. I've been asked to talk today about X-linked Hyper IgM and transplantation. And I have talked about this before to some of you. There's a little bit that's changed, but not much. And I would be more than happy at the end of the talk to answer any questions that I can. Now, actually, having arrived on the call late, I'm not sure what I do with the slides. Nothing. So can I have the next slide, please? I am going to present published data on the outcomes of patients with CD40 ligand deficiency, with or without transplantation. And that will include some mortality statistics. And if you'd rather not hear about that, then I certainly respect that, but I'm just warning you that that information will be out there. Next slide, please. So when I grew up in the field, I was always taught that CD40 ligand deficiency was an antibody deficiency. And this is an old slide of mine from over 20 years ago, which shows the B cell, immunoglobulin IgA, IgG, and IgM interacting with other cells as well. Next slide, please. But it's not a B cell deficiency. What it is it's a T cell deficiency leading to a combined immune deficiency. And this is the important part of that previous slide. It's the T cell interacting with a Kupffer cell, which is a special macrophage cell that lives in the liver, and T cells interacting with other macrophages, particularly in the lung, but elsewhere as well. And that's important because B cells make antibody. And whilst actually I think even a B cell deficiency is more complicated than maybe we used to think, a T cell deficiency is definitely one up from a B cell deficiency, an antibody deficiency. Next slide, please. And to illustrate this, we have this nice graph from about 10 years ago now from the group in Paris, which shows the risk of, or actually the chances of remaining free of a particular germ called a non-typable Haemophilus. It's a bacteria, and it's the chances of remaining free of that by not carrying it in your nose and throat. And in the top line is patients with hyper IgM, and in the bottom line is patients with primary hypogammaglobulinemia or antibody deficiency. And you can see that the bottom line, patients are much less likely to be free of carriage. In other words, they're much more likely to carry this bacteria than are patients with hyper IgM syndrome. And that's because actually hyper IgM patients do have antibody. It might only be IgM, but it does have some effect at protecting from some bacterial infections. And so it is not simply an antibody deficiency. And in terms of antibody protection, patients with hyper IgM syndrome are maybe better off than patients with, for instance, X-linked agammaglobulinemia. Next slide, please. What it is, however, is a T cell deficiency, and that really does up the ante. So patients with hyper IgM syndrome, CD40 ligand deficiency, and I put in brackets CD40 deficiency, which is kind of the other end of that protein interaction, much more rare, are upper or lower respiratory tract infections from infancy, often due to bacteria. But the things that really make us worried are the pneumocystis infection that patients can have, the Giardia, or particularly the Cryptosporidium, that can lead to diarrhea, but also will lead to a sclerosing cholangitis, which is inflammation and scarring of the bile ducts. We do find a neutropenia with mouth inflammation and mouth ulcers. But the scarring of the bile ducts can lead to cancer in the liver, hepatocellular carcinoma. And we also see, and we do see this with antibody deficiencies as well, meningoencephalitis, or a brain infection, often due to virus rather than bacteria. And it's things like enterovirus. And that can be an important complication as patients get older. Next slide, please. So I couldn't remember why I put this slide in, and it's really just remind ourselves that we're dealing with history here. For those of you that recognize it, this is the Joshua Tree cover from U2's album, which actually remarkably was in what, 1987. To those of us that grew up with U2, it maybe seems not so long ago, but it's truly historic, and it's only, well, 2 or 3 years ago now, 5 years ago, in fact, that they had their 30-year anniversary of the Joshua Tree. And the reason I say that is because whenever we're looking at data regarding any primary immunodeficiency, but in this case, CD40 ligand deficiency, we're looking at historic data. So we're gathering data from patients that gave data maybe 5 years ago, or 10 years ago, or 15 or 20 years ago. And we're now presented with that data, and we shouldn't think necessarily that's what happens today because things have changed. And I think that's a caveat that we just need to remember when we are looking at the data that I'm going to be presenting. Often that is historic data and things have moved on and may actually be better than I am seeming to present. Next slide, please. So this is an important manuscript from what, 6 years ago or so now, from Teresa de la Morena, who is now in Seattle. And she did a big multi-center study around the world of 176 patients with Hyper IgM syndrome. Many of those were diagnosed as having CD40 ligand deficiency, but some of them may have had something else. And this is a survival probability. So this is a survival curve, and it's the chances of you being alive at various times. And you can see that when we were looking in early childhood, there were lots of patients. And when we looked later on, then there were very few patients. But again, going back to the story of U2 and the Joshua tree, this was now data that are over 35 years old. So what we're saying is, if you were born over 35 years ago and you had CD40 ligand deficiency, there is less of a chance that you'd be alive today than if you were born today. And I think if we extrapolate patients who are living today and are 5, 6, 7 years or less, then the chances of them being alive and relatively healthy in 30, 35 years time are much better than this curve suggests, because our understanding of the disease, our treatments have progressed, and there are many patients who probably weren't even diagnosed when they were sort of 30, 35-year-old patients now maybe weren't diagnosed until they were teenagers or early adulthood. So things have moved on, but even so, this does give us some idea that over time there is a mortality with this disease. And I think that's an important message. Living with this disease, there is a mortality associated with it. Next slide, please. These data show a mixed picture of patients, a dotted line who'd had a transplant, and in the smooth line, patients who had not been transplanted. This is from that same series of 176 patients. And statistically, there is no difference in survival. Now, I think there are some problems with these data. Again, they're historic. We don't know which centers were putting the data in. Next slide, please. And what this shows us is the chances if you had liver disease when you were diagnosed of being alive or not. And you can see that, importantly, if you didn't have liver disease, your outlook on a longer healthy life is much, much better than if you already have liver disease. And when we're talking about liver disease, probably we're talking about patients who've contracted cryptosporidial infection, have gone on to develop sclerosing cholangitis, maybe cirrhosis, perhaps leading eventually to liver failure, or indeed hepatocellular carcinoma, liver cancer. And so cryptosporidial infection and then the liver disease which can follow that are really important indicators of health and of long-term survival. Next slide, please. This is a table taken from that paper, looking at the cause of death in patients who didn't have a transplant. And if you look through, you can see malignancy with gallbladder and rectal cancer. Cholangiocarcinoma is cancer in the gallbladder. Neuroendocrine tumors, another cholangiocarcinoma, liver failure. So these are all either significant infections with things like pneumocystis, or problems associated with the liver, which ultimately are likely to come from cryptosporidium infection. So not having a transplant for these patients has clearly been important. But again, this is historic, and one would hope today that we have some better ways of treating some of these problems, or preventing at least some of these problems. Next slide, please. So, I mean, our standard treatments for patients with CD40 ligand deficiency, first of all, immunoglobulin substitution. Secondly, pneumocystis prophylaxis, normally in the form of cotrimoxazole. Cryptosporidial prophylaxis, which is a little bit more difficult, we would advise that patients boil water, and that includes the water that they use, for instance, to brush their teeth. There's a question about azithromycin may have a role in cryptosporidial prophylaxis. We certainly recommend it for our patients, but I'm not sure precisely how effective that is. It does have some role against protecting against lung disease also. And then for cryptosporidium, there aren't really any very effective treatments. Paromomycin and nitazoxanide are recommended, but actually, in order to clear cryptosporidium, you need a good functioning immune system, and just being on those antimicrobials isn't really enough. Hematopoietic stem cell transplantation, because that's what we're talking about today. And then in brackets, gene therapy, which isn't available at the moment, but actually may be available for some patients fairly soon. So we first published about CD40 ligand transplant outcomes, back in 2003. It seems a long time ago now. And this was a retrospective analysis of only 38 patients who'd been transplanted for CD40 ligand deficiency in 13 centres in 8 European countries. And again, these are historic data. So this was 10 years between 1993 and 2002. You can see from the figures there that the overall survival, perhaps in those days wasn't so bad, 70%, but with a cure rate of about 60%, because some patients had autologous reconstitution, so they got their own bone marrow back and still had CD40 ligand deficiency. And we found that pre-existing lung damage was the most important adverse risk factor. I think we were a bit surprised at that because we thought liver disease might be, and said at the time that further studies will determine optimal timing and type of transplant. Next slide, please. And so indeed, that is what we did. And this was a big manuscript that we published in 2019. It was a joint effort from the Inborn Errors Working Party in Europe, including SCETID database, which is particularly the primary immunodeficiency transplant database, as well as the Primary Immunodeficiency Treatment Consortium in North America. So it really was a collaborative effort across the continents. Next slide, please. And this is the kind of summary cartoon, if you like, at the beginning of the paper. And you can see significantly more patients, 130 patients who underwent transplant for CD40 ligand deficiency in 36 transplant centres worldwide. The data are kind of summarized there, but I have those data in a few graphs going forward. So we'll look at that. Next slide, please. So this shows outcomes according to age at transplant. And we've also split it into patients transplanted before the year 2000 and after the year 2000. And 2000 is often a magic year in terms of transplantation history, because it's when things kind of really began to get better. Our tissue typing was much more accurate, so that we knew, for instance, that matched unrelated donors really were matched. We had ways of measuring infection in the blood before it was causing disease, particularly looking at viruses in the blood measured by PCR, which we could determine on routine testing before patients were symptomatic, and actually had some treatments that we were able to offer to counter those infections. Our conditioning treatments were getting less toxic and perhaps more effective. And just generally, the whole package of care around transplantation was improving with more knowledge and more time. And so transplants generally seem to have got better, with better results from 2000. But I think what this graph shows that if you were transplanted before the age of 5 years, you had the best outcomes if it was after 2000. But even so, the outcomes after 2000 were also better for older patients. Patients who were transplanted before 2000, then the outcomes were close to 80% versus close to 90% for now. And patients who did worse were the older patients, and that was true whichever era you were transplanted in. Can you click the slide again, please? So this is not a new finding for CD40 ligand deficiency. The second set of graphs are taken from, again, a recent publication looking at a different disease, chronic granulomatous disease. And what you can see is that if you look at the overall survival by age, then it is worse in patients who are older than patients who are younger. And the reason for that is probably not simply age. Sorry, the top one actually is for Wiskott-Aldrich syndrome. The bottom one is for chronic granulomatous disease. So both of those show an age-related issue. And the issue is not age per se, but it's the fact that the older you are, the more likely you are to have picked up serious infection or sustained organ damage because of infection. So in CD40 ligand deficiency, you're more likely to have lung disease or liver disease than if you are younger. Again, I don't think there's anything magic about the age of 5. It's something that we tend to use, but older patients tend not to do as well as younger patients. Next slide, please. Next slide. Yeah. So this is kind of reinforces what I was saying when we look at sclerosing cholangitis, which is the particular liver problem associated with CD40 ligand deficiency, or in panel B, organ damage before transplant. And you can see that the better survival curves, again, are in younger patients, but in patients who don't have organ damage or sclerosing cholangitis. There were some differences in panel D about donor, and I think an important message in panel F is that there are some important differences depending on the type of chemotherapy conditioning that we use. And we have previously used what is known as a reduced intensity conditioning. We've tended to use that in older, sicker patients because they won't necessarily tolerate harder chemotherapy, if you like. And those patients tend not to have done so well, partly maybe because they were sicker anyway, and partly because you probably need fairly good chemotherapy to clear the marrow out in CD40 ligand deficiency in order to get a good graft in. Next slide, please. And again. Oh, right. This isn't what I was expecting, actually. No, sorry, go forward. I think this is a problem with a MAC and not a MAC. So this is showing us what we call donor chimerism. So this is the amount of donor cells that are in the bone marrow or in the blood as opposed to the patient cells. And it's quite tricky to look at this, but I think the main message to come through is that you're more likely to have good donor chimerism in the bottom two panels if you didn't have viral infections during the transplant than if you did have viral infections during the transplant. And I think the reason for that is that whilst patients with CD40 ligand deficiency have an abnormal immune system, parts of that immunity are actually very good and in fact are probably normal. And so patients can fight viruses. And so you can imagine a situation in a transplant where you've given chemotherapy, maybe not got rid of all of the patient's T cells, and then they get a virus during the transplant. CMV is normally one that reactivates, and the patient's own cells might then respond to the CMV, and during that response they proliferate and they expand, and they're doing that to get rid of the virus, and therefore we find a lot of recipient T cells as well as donor T cells, and as well as fighting the virus, they can then decide to reject the graft as well, and you can end up with graft rejection. And I know there's this concern that transplanting patients with CD40 ligand deficiency can be tricky. I think I've been asked to talk about that before. I think it can be a little bit tricky, and I think this is one of the reasons for it, that because patients do have an intact immune system, at least to some degree, when we get viral infection, particularly in older patients, then we can find this mixed chimerism and we can find rejection. Next slide, please. So this shows the causes of death in patients who had undergone transplant from that big series. You can see the biggest cause of death is infection, predominantly early infection, but also later infections. And then graft versus host disease, particularly if there's infection around. Graft rejection, liver failure and multi-organ failure are more likely in patients who have pre-existing liver disease. PML is neurological deterioration, as is progressive neurodegeneration. And again, this is probably in older patients who have maybe an occult virus enteroviral infection in the brain. Maybe it's not been picked up and they've not been particularly sick, but when they get normal immunity, you get an immunological reaction to that virus in the brain, and that can cause brain damage. And then we can see deteriorating liver function and GVHD as well. Next slide, please. So I think the key messages from this big paper were that transplant can be curative in patients with CD40 ligand deficiency, and the best outcome is if it's performed before patients are 10 years old, and preferably without organ damage, and particularly liver disease such as sclerosing cholangitis. We found better survival with matched donors and transplant early after diagnosis, and the use of myeloablative conditioning gave a better overall survival and also disease-free survival. And event-free survival, and events include things like graft versus host disease, infection and rejection, improved when we had matched sibling donors, myeloablative conditioning and bone marrow as the stem cell source. And reduced intensity and non-myeloablative conditioning were associated with poor donor cell engraftment. Next slide, please. So what I'm going to do now is tell you about our own centre's experience, and it doesn't exactly mirror what that big paper says. I think big multi-centre papers are important because they kind of give a world view of what's going on, but you will know from whatever fields of life you are in that there are centres of excellence, and centres of excellence can sometimes produce results that don't necessarily follow what the multi-centre story shows. And so this is a manuscript that we have only just published. I don't think that it's in print yet, although it is available in press. If you go on to the internet, you should be able to find that from PubMed and download it. I think Akiva may have access to a copy, and I'd be very happy for it to be circulated for those that can't get hold of it, or if you want to email me, I'm happy to send you a copy. Next slide, please. So we had 23 patients. The median age at the diagnosis was 1.5 years, but some patients were diagnosed at birth on the basis of family history. Some patients were much older. You can see that the median age at transplant was about 3.5 years of age, but again, there was a range. And there was a range in terms of interval between diagnosis and transplant. We are transplanters. We firmly believe in transplant for CD40 ligand deficiency. And so if we've made the decision to transplant, then we don't tend to leave it too long. Next slide, please. So these are the characteristics of patients and particularly donors. So you can see that the majority of donors were matched, so matched family or matched unrelated donors. We've done some mismatched unrelated donors, and also 3 half-matched parents. And although predominantly we had used marrow, there were 4 patients who used peripheral blood. And I have to say that we have really moved our stem cell source from marrow pretty much to peripheral blood as much as we can these days, because you get a much better stem cell dose, and I think a better chance of getting engraftment. Next slide, please. These show you the conditioning regimens, because this is a whole series. So about half the patients got our standard conditioning historically of busulfan cyclophosphamide. 1 patient got reduced intensity fludarabine melphalan because they were sick. But the majority of patients today get our treosulfan-based conditioning of treosulfan and fludarabine, and increasingly we're giving thiatepa as well. Most patients get serotherapy, either alemtuzumab campath or ATG, and our conditioning protocols these days are standard. So it really depends on which donor we use as to which conditioning regimen we would be offering. But they will all these days contain treosulfan. Next slide, please. So now we can look at some of the results. So this is the overall survival of all of those patients over the entire period. And you can see that whoever walks through the door with CD40 ligand deficiency, then we have an overall survival of 82%. I think what's important to notice is that the deaths are early. So if you get to about 6 months post-transplant, then the chances are you are going to survive in the long term. And I would say live a long normal life at that stage, or certainly you will be cured of the disease and shouldn't have any late deaths due to transplant. Next slide, please. When we split it, we do find some differences. So looking at patients transplanted after 2007 or 2007 compared to before 2007, there are differences in overall survival and event-free survival. Now, we use 2007 because that was when we started using treosulfan rather than busulfan. And you can see that our treosulfan results are very good indeed. But, and there is another historic anomaly and caveat here, part of the reason our results since 2007 are so good is probably to do with the fact that we're using treosulfan, but also we're generally transplanting patients who are younger and fitter, and we have better methods of detecting virus, and just generally our approach to transplant is better than it was in 2000. So I am sure that treosulfan had a role to play in this, but I don't think it's simply treosulfan. I think it's part of the whole package. Next slide, please. So the things that were predictive of a better survival were year at transplant, as I've explained, age at transplant, and 3.6 years, 3.5 years did better than a bit older, generally, statistically at least. Having pre-transplant liver disease was a poor indicator, and treosulfan gave us a better survival than treating patients with busulfan. But as I say, there are some caveats in that we just need to think about as well. Next slide, please. So our conclusion, and I think this is a conclusion of the whole talk, is that transplantation is or can be curative. And most of our patients are off immunoglobulin, and indeed off other prophylaxis as well. The immunoglobulin, actually, I'm less worried about, because our patients don't tend to die of bronchiectasis, they tend to die of liver disease, and not for CD40 ligand particularly, but pneumocystis is also a serious infection. So it's the fact that patients no longer have a T-cell immune deficiency that's most important. Being off immunoglobulin is great, but actually we do have 1 or 2 patients that remain on immunoglobulin, and I'm okay with that. Our best outcomes are found if we transplant at an early age, especially if we do it before there's significant organ damage. We use reduced toxicity myeloablation rather than our previous toxic myeloablative conditioning. And even places that don't have access to treosulfan tend to use targeted busulfan conditioning regimens these days, which is also reduced toxicity compared to the olden days. And lack of viral infection is associated with better engraftment. So I think my main message would be that we should consider transplant early. And I would argue as families that you need access to transplanters so that you can talk to them about transplant options. Now, that doesn't mean that you as a family or that the transplanter necessarily have to agree to the transplant at that point. But what upsets me is when we get patients who are old and sick, and the immunologist looking after the patient has not wanted to refer because they consider that transplant is dangerous. And then they wait until the patient is old and sick, when transplant definitely is dangerous. I would like you as families and patients to be able to make those decisions for yourself in conjunction with the transplanter, who should have up-to-date information about survival with transplant in the modern era, and not be relying on historic data, which is no longer relevant and not useful to you making any decisions. Next slide, please. So this is my final slide, and it's really just acknowledging the people that have been involved in getting these data out. Mary Slatter, Andrew Kant, and Suhan Lum, who I work with in Newcastle. Andrew's retired now, actually, but certainly taught me much of what I know about transplant. Francesca Ferrua, who was my fellow when she led on the big Inborn Errors and American study that was recently published, Teresa de la Morena in Seattle, who did the general survival of Hyper IgM syndrome, and then the team in the Sketted office as well. So I'm going to leave it there, because I think probably the most important part about this webinar is not me talking, but rather you talking and maybe asking me questions. So thank you very much for your time, and I'm happy to try and answer your questions if I can.
Wonderful. Well, thank you so much, Dr. Gennery. That was so informative. Actually, before we dive into Q&A, first of all, I do want to remind everyone and encourage everyone to input any questions they have into the Q&A box on the control panel at the bottom of your screen. So feel free to take a few moments to go ahead and ask your questions. And then in the meantime, I'm now going to turn it over to Akiva Zablocki, who is the president and founder of the Hyper IgM Foundation. Welcome, Akiva.
So thank you very much, Dr. Gennery, for that really insightful talk, and for IDF for putting this together. Just a few announcements, and then we'll jump into the Q&A, and then maybe that will give a chance for things to come in. We recently completed, and thank you for everyone that participated, our Hyper IgM carrier survey. We had, I think it closed with 67 respondents, and that's really amazing for our community. The data now has been passed along to our researchers in Emory, who are going to analyze it, and hopefully we'll be able to publish this by the end of the year. On that note, with the research grants, I want to mention again, and most of you probably have seen this, in 2022, we're offering $100,000 in grants for scientific research, with the goal of improving treatment quality of life and long-term outlook for our patients. And I'll mention that almost half of the funding that we end up raising, half of the funds that we raise every year, come from our community. And it comes from families, patients, relatives, people who just know you guys, starting Facebook fundraisers, whether it's for their birthday or for a transplant date, or part of one of the bigger campaigns like Giving Tuesday. And that raises almost half of what we ever bring in. So I'm turning to all of you here, again, if you have a chance this year to raise funds to help us reach our goal, because we're definitely funding the $100,000, but you guys would help us reach that goal with starting fundraisers. On that note, I will mention that in the last week of April, which is World PI Week, we're going to have a fundraiser called Hyper IgM Virtual 5K. We've done this a couple of years ago. It's going to be a week where anybody that can register to run a 5K. You could also just walk it. You could also just do it at home on your bicycle. You could roll out of bed and into bed a few times to reach the 5K. But essentially, during that time, during that week, you'll be raising awareness and also starting a small fundraiser for the cause. Last year, we raised close to $10,000 from the virtual 5K. So we're hoping people can join us again during World PI Week. And lastly, I'll mention that we're working on a webinar on IVF and PGD, something that's very important for our community, as the majority of our patients have X-linked Hyper IgM. And we're working out together with a couple of other organizations that are focused on X-linked rare diseases, and most likely it will be on May 7th, so stay tuned for that information. And with that, I think we are done. So I will stop sharing my screen and we could move on. Thank you.
All right, wonderful. Thank you, Akiva. And again, thank you so much, Dr. Gennery. We've gotten a couple of great questions in the meantime, so we'll go ahead and start off with our Q&A. All right, first question is, can one have Hyper IgM without CD40 ligand deficiency? My providers have no idea what to do with me. I am a 52-year-old female.
So yes, you can. You can actually very, very, very rarely have CD40 ligand deficiency and be a female. Although it's an X-linked disease, we do know that you can rarely be a female and affected, although generally we say that carriers are not affected. So I think I've discussed this with Akiva in the past, because one of the problems is that Hyper IgM syndrome is a description of having high IgM. It is not a description of having CD40 ligand deficiency. And we know that there are a number of other diseases that can give you a high IgM. I would have thought in a 52-year-old female, I would be worried about something called PI3 kinase deficiency. And that's probably asking your provider to think about. I would have thought that's the most likely thing that's going on.
Thank you. All right, next question. How much of the success rate of the transplant is based on the donor's age and other qualities of the donor?
Yeah, so that's a really interesting question. And I think there's a number of ways to answer it. I was in Leiden in the Netherlands last week with Arjen Lancaster, who's a colleague of mine, and we were having this really interesting discussion, because you will know that the best donor for bone marrow transplant is a matched brother or sister, because that's what we tell you. And that was true. But I don't think that is true today, actually. I think it is clear from the published data that a matched unrelated donor who is well matched gives you at least the same outcome as a matched sibling donor. And increasingly, with clever ways of engineering grafts and manipulating stem cells when it's not a proper match, particularly a half match where we use a parent, but we can also use unrelated donors that are not so well matched. Actually, the results are pretty much the same. So I would argue today that a transplant outcome doesn't so much depend on the donor that you use, but actually on the condition of the patient when you come to transplant. And the donor doesn't really make that much difference. Now, I think there's a much more interesting philosophical discussion to be had about whether in a young child, transplanting stem cells from, for instance, cord blood versus maybe a 52-year-old donor is important in the very long term. And the short answer is we don't know the answer to that. But I think from a practical perspective, if you're looking for a donor, these days I don't mind. I don't worry that we're not going to find a donor, because we will. And if they're a mismatched donor, we'll do a T-cell depleted transplant, and the outcome is unlikely to be any different from using a matched unrelated or a matched sibling donor.
Thank you, Dr. Gennery. All right, next question. We actually had two folks ask this, so we'll consolidate into one. How early do you recommend transplant in prenatal diagnosis, and is there a role for cord blood banking for autologous transplant?
So the first, I'm going to answer the second bit first. No is the answer. In CD40 ligand deficiency, the defect is in the bone marrow, which is also the cells that we find in cord blood. And so what you would be doing is transplanting faulty cord blood cells in place of faulty bone marrow, and you will end up with a disease. You won't have treated anything. So there is certainly no role for using autologous cord blood for transplant. What I would say is that there are a number of people around the world who would be very interested in CD40 ligand deficient cord blood cells for thinking about gene therapy. If that's a situation you might be in, then there would be people that would be potentially interested in looking at that cord blood, but at the moment it's not for treatment. In terms of recommending transplant, we've got some time actually. If we've got a very early diagnosis, either a prenatal or a diagnosis at birth, we can start a patient on immunoglobulin and we can start prophylaxis. And the risks that I've talked about are going to accumulate with time and age, but are generally not there very, very rapidly. And so we wouldn't be looking to transplant a newly diagnosed baby who has CD40 ligand deficiency until somewhere between about 6 and 12 months, because we do have some slight concerns about giving chemotherapy to very, very young children. We do actually give it to 6-week-old babies with SCID, because I think we don't really have a choice. But I think if I had a choice, I would be comfortable in waiting to somewhere between 6 and 12 months. And there's a number of reasons for that, the chemotherapy, but also there are some psychological things. So not so much waiting to 6 months, but actually you think about what a 6 month, 9 months, 12-month-old child wants, and it's to be with their family, particularly usually their mother, and they want to be played with and they want to be stimulated. What they generally don't want is an iPad and to go out with their friends. If you are transplanting a young infant, you are not dealing with all of the other psychological issues that go with transplanting older children, adolescents who have other concerns and other fears, and also, maybe worries about the transplant process. If you talk to infants or talk to patients who were transplanted as an infant, they don't remember anything about it. You talk to children who were 10, 11, 12 about their transplant, and they can tell you about what they thought about it because they do remember it. And I would much rather transplant someone who is fit, young, and healthy than in someone who is a bit older, a bit sicker, and also is going to remember more about it. I hope that answers the question.
Yes, thank you. And thank you everyone for your questions. These are great. All right, next question. Is there anything before HSCT that can help with mouth issues such as inflammation, ulcers, bleeding, etc., specifically for a 2-year-old child?
Not really, actually. I can't think of anything particular other than the general and normal mouth care that you would institute. It would be worth just checking that they're not neutropenic, because neutropenia can lead to mouth ulcers. And for instance, if they were very neutropenic, then your doctor might want to give an injection called GCSF to try and stimulate the neutrophils. But if they're getting mouth ulcers and they're not neutropenic, I don't have any magic solutions for that other than kind of standard oral hygiene, to be honest.
All right, thank you. All right, next question. HSCT seems to be curative for hyper IgM associated liver disease. Is that because it restores immune function to protect against crypto, or is it because the CD40 ligand function in non-B cell pathways, such as the T cell, Kupffer cell interaction you mentioned at the start of your talk?
Yeah, no, that's a good question. So actually the bone marrow is great because it goes on to make all of these cells. It makes T cells, it makes B cells, it makes macrophages, it makes neutrophils. And so when we do a bone marrow transplant for CD40 ligand deficiency, we actually replace all of those. But I think the main thing is actually that you are replacing T cells that then have CD40 ligand expressed and are able to interact with the CD40 that we find on macrophages. So you could get a good and useful interaction between a donor T cell and a patient's macrophage, because the macrophages are functional. But actually, in practice, if you've got a successful transplant, you're probably going to have changed most of those cells anyway.
Thank you. All right, and our last question is, prior to transplant, what are the best testing to do to make sure there are no issues during transplant?
Listen to your doctor. Yeah, I mean, stay healthy, take the medication that you've been given, or get your child to take the medication that they've been given. Cryptosporidium, I think, is the big issue. So, I mean, I don't know how much crypto there is in the States. We certainly got it in the UK and other parts of Europe. So we would say boiled water, and you need to be careful because bottled water could have cryptosporidium as well. Just because it's bottled doesn't necessarily mean that it's safe. Yeah, so I mean, trying to avoid situations where you may catch disease, taking your medication. And I mean, that's another reason for, I think, transplanting kids when they're fairly young, because getting teenagers to take their medicine can be a little bit tricky, particularly teenage boys, but I think teenage girls can also be tricky as well, because they don't really see the need for it. I think it's much easier to get young kids to take their medicine because they won't argue with their mothers usually. But yeah, I mean, staying healthy and infection free in the best way that you can.
Wonderful. Well, thank you so much again, Dr. Gennery, and thank you, Akiva, both for your presentations today.
There's one more question just come up actually.
Yes, one more did. Yep, and I will read it.
Expectancy is in the 20s without transplant for hyper IgM. I mean, that's a difficult question to answer, to be honest. I think if you're not transplanted but you're on medication, I would expect the life expectancy to be higher. But the problem is you need to avoid the thing that's going to kill you, which is probably going to be Cryptosporidium, but it could be another microbe. And actually avoiding those isn't necessarily as straightforward as we think. And I certainly know of patients who have been on appropriate medication who have died in their early or late teens. I also look after a child who we have transplanted, whose grandfather, I think, is in his 50s and hasn't been transplanted and also doesn't take his medication very often. And he's okay. I'm not sure he's as fit as a fiddle, but, you know, he's reasonably healthy. I think he goes swimming. You know, I've met him and we've had a conversation, and you could certainly go out for a walk with him. So I think it's a bit variable. And the problem is we focus on the single gene CD40 ligand deficiency, but I think the outcome of these diseases is that single gene defect is important, but there are lots of other genes that we carry that may also modify how we respond to infection. And then the environment is important as well. I don't know how many of you are historians, but I read today that the ship that Ernest Shackleton sailed to the South Pole on, called the Endurance, has just been found. It sank 107 years ago, and they found it at 9,000 feet on the seabed just at the weekend. It is almost perfectly preserved because in the Antarctic waters, there are no microbes that eat wood because there are no trees in the Antarctic. If that boat had sunk off Europe or off the States, probably there would be nothing left after 107 years because it would have been eaten by wood-eating worms or other microbes that eat wood. So the environment in which you are in, as well as your genetic problem, is also important. And you can't always control the environment quite so well. But I think life expectancy, I would hope, is more than 20s these days. But I still think if you're looking for cure, actually, you should be thinking about transplant. And it was very interesting talking to the grandfather that I just mentioned, because he said to me, I wish someone would transplant me these days, because every day I wake up and wonder what's around the corner. And it would be so much easier to wake up without having to have those worries.
All right, and a couple more came in. So if we want to keep going with the Q&A, we do have about 5 more minutes. Do you want to keep going with that, Dr. Gennery?
Yeah, I'm happy.
Okay.
FFP3 mask, do I think it's worth continuing to use it to prevent, minimize, or lower the risk of airborne infections? I don't know the answer to that. I mean, I don't even know what COVID is like with you guys at the moment. If you can cope with living with an FFP3, good for you. To be honest, they drive me round the bend. Yes, I suspect it would prevent you getting some infections, and if it's something that you think you can do, then, you know, absolutely. And then Andy Hyder has talked about our paper. There's a patient with only about 10% CD40 ligand function. Feel slightly tricky about this patient. He's actually doing better than we might have imagined, but we would have considered, for instance, topping him up if we'd been able to access the donor, but we weren't able to do that. I think these days we would prefer more than 10% CD40 ligand function, but this patient is well. I don't know what the minimum that we need is. Probably 10% is around the minimum, but I would be nervous at that level. I would prefer over 50%, I have to say.
All right, well, thank you so much, everyone, for your participation and engagement with the Q&A. That was great. Thank you again, of course, to Dr. Gennery for this awesome presentation. We hope that you'll remember to take advantage of all of the resources that IDF has to offer. To explore our resources for Hyper IgM syndrome, visit our website and search Hyper IgM. or visit the IDF Resource Center. And we also have several videos of past Hyper IgM presentations from conferences and past events like the one you're at today. And we also have stories from real patients on our IDF YouTube channel. So we definitely encourage you to go check those out. If you have additional questions, you can ask IDF. Go online and submit your questions to Ask IDF at www.primary-immune.org/ask-IDF, or give us a call at the number on your screen. We want to close out by saying that IDF programming is truly guided by the individuals and families we serve in our community. And therefore, we hope you will take a moment to scan the code on your screen and take our very brief program evaluation survey. And I will also be emailing this out to everyone after the fact, so please take our survey. Lastly, we hope you will join us for the next IDF Lunch and Learn taking place on March 23rd, where we will take a look at SCID and family planning with our program partners over at Expecting Health. So thank you again, Dr. Gennery, thank you, Akiva, and thank you everyone for joining us for today's program. Thank you for all of your participation and engagement. We really appreciate it. And we hope to see you at another Lunch and Learn soon. So thank you and have a wonderful rest of your day.
Thank you.